Science Conference. Welcome back in person and online. Wanted to start with a couple of housekeeping items. For our online attendees, please keep your microphones muted unless you are speaking and presenting remotely. We do have live captioning available. To turn on captions, you will hit the live transcript button. It shows a CC to view the captions that are being streamed live. For Wi-Fi, if you have any questions here, let me know. We'll get you set up with all the information you need. And for our online attendees, I encourage you to check out our conference website, where we have all of our information about the conference. You can learn all about our great speakers and reading their bios. Also, you can see our showcase items from yesterday's TechSAge showcase on display. Lots of great posters and videos to check out about our center. At this time, I'd like to pass it over to Wendy Rogers, who will be giving an introduction to our speakers this morning. Thank you.
Thanks, Elena. Welcome back, everybody. It's just a thrill to have the Illinois Department on Aging represented here at our conference today and be willing to provide some opening remarks for us. Amy Lulich is a senior policy advisor with over a decade of experience in healthcare policy. She's been the lead on both developing and now implementing, I just got my copy the other day, of the new Illinois State Plan on Aging. And this is very exciting. And I'm guessing that she's going to tell us a little bit about some of that work and other things that the Illinois Department on Aging is doing. They're a great partner for us. Paula Basta and Lori McCurdy are really very engaged in what we're doing and always willing to write letters of support and help us with work that we're doing. Brian Pastor, who used to work here with us, is now at the Illinois Department on Aging. We also work closely with Amy Brown, who's now at the Illinois Department on Aging. So we have a strong connection. And I think that's really important for something like TechSAge, where you want to do the R&D and the training, but also the dissemination. And I think that's key. So I won't spend any more time. I'll just welcome Amy Lulich to make her remarks.
Feel free to go ahead and get started.
Oh, okay, great. Well, thank you for having me at the conference today. Again, Amy Lulich, Senior Policy Advisor for the Illinois Department on Aging. I'm pleased to join you on behalf of Director Paula Basta, who unfortunately could not be here today, but I'm very excited to be representing the department on the kickoff to day 2 of the State of the Science Conference. So I was mentioning earlier that I worked at the University of Illinois Health System, UI Health, the university's health enterprise, for about 7 years. And so it's nice to be amongst people who are researchers who are also translating that research into practice. I think that it was always such a joy for me when I would go and talk with a physician researcher or an academic colleague who had this great idea, and then we were able to see that and put that into practice for patients and community members. So our mission at the Department on Aging is to keep older adults in their homes and communities for as long as possible with the appropriate services and supports. We know that the intersection of aging and disability presents unique challenges to people who are both managing, both. That is the natural occurrence of growing older along with physical, intellectual, or developmental disability that they were either born with or acquired later in life. These challenges are oftentimes amplified by a lack of integration across aging and disability fields. Programs and policies that provide long-term services and supports to individuals with disabilities have traditionally been segmented by the age of the participant and the nature of their disability. This historical practice has created silos dividing aging and disability programs and services into distinct recipient groups. This division isn't beneficial to people who may belong to more than one group. And that's why state agencies and Illinois lawmakers are working to change the landscape on which aging and disability silos are built. For example, about a decade ago, the Illinois General Assembly passed legislation expanding what was previously the Elder Abuse and Neglect Program, now called the Adult Protective Services Program, to include investigations of abuse, neglect, and exploitation for persons with disabilities and older adults ages 18 to 59. A more recent example of bridging the aging and disability service networks is the Illinois Care Connections Program. This is a collaborative program with the Department on Aging and the Illinois Department on Human Services, divisions of rehabilitation services and developmental disabilities, that provides assistive technology devices to socially isolated seniors and persons with disabilities in Illinois. This program launched in 2020 during the height of the pandemic and was supported through a $1.7 million grant from the Federal Administration for Community Living. And this was an allocation through the Federal CARES Act, for those of you who are familiar with that. While the two departments made referrals to the program, our partner, the Illinois Assistive Technology Program, implemented it by processing referrals, purchasing and assembling technology bundles for each participant, and shipped the bundles to recipients' homes. Based on need, the bundles include a tablet device, case, headset, keyboard, Wi-Fi hotspot, a really comprehensive user guide. We did they created a step-by-step user guide with pictures, and we translated that into multiple languages for both iPads and tablets. Information about the Wellness Recovery Action Plan, which is for those of you who aren't familiar, was developed by Judith, and I'm going to blank on her last name, but she's a professor at the University of Illinois in Chicago, and I think in the Department of Psychology. And so we partnered with them to provide some activities for older adults and persons with disabilities who are getting the tablets to be able to get involved in. And then any other assistive technology needed for access and use. The Illinois Assistive Technology Program and the University of Illinois at Chicago Assistive Technology Unit, so right here in Chicago, also provided telephonic and online technical assistance to participants who needed help setting up or operating their device. So we know that it's not just putting a device in the hands of older adults, but we need to make sure that they have the tools and resources to get help to use the device.
The slides aren't scrolling, so if you want to periodically click and show
I'll
some
do
new
that.
ones,
Yeah,
we'll hear more from the seniors.
Yeah,
Thank you.
absolutely.
Don't want to miss out on these great quotes.
No worries.
Well, that doesn't appear to be working.
That's okay. I'll keep going.
Sounds good.
While you work on that. So even before COVID, social isolation was a major concern among older adults and persons with disabilities. And with the Illinois Care Connections Program, we really wanted to help those who were experiencing loneliness and a lack of connectedness. So if you're familiar with in Illinois, across the state, we have senior centers and adult day services programs. So these are, senior centers are places where adults could go and, have socialization, have a hot meal, get involved in activities, exercise, have coffee. Adult day centers are similar in that it was kind of a respite for a caregiver to, it's kind of informally called adult daycare. But those had to shut down at the beginning of COVID. You could not have, groups of older adults congregating together. And so what did that mean? We had thousands of older adults and persons with disabilities. There's a similar programs for persons with disabilities going out in the community, day programs. They were at home. So we wanted to make sure that we were doing something to help them continue to be able to connect. We do have some data on the success of the program, specifically on how it reduced loneliness amongst tablet bundle recipients, which I'd like to briefly summarize. So this was, we just had a kind of like annual report or year-end report. Illinois Assistive Technology Program did this for us. It's really great. You can, I'll make sure that Alina has the links later. You can take a look at the report. It's very, very well done. And they just published, they just published a briefing with the Administration on Community Living too as well. That was just posted on the ACL website. So the UCLA 3-question loneliness rating scale It's a condensed version of a 20-question assessment, was administered at the time of client referral to identify a baseline rating of loneliness, and again, approximately 2 months after the recipient of the tablet bundle to identify any change in level of loneliness. This scale provides a rating of 3 to 9, with the ratings of 3 to 5 identified as not lonely, and the ratings of 6 to 9 as lonely. A total of 2,078 tablet bundle recipients have pre and post loneliness rating scale scores. And the overall mean change in the rating was 1.9 points, moving from a baseline rating of 7.1, which is the mid-range of lonely, to 5.2, which is at the top of the not lonely range. Of course, in the report, you'll see the different, the change in loneliness for the different populations. So older adults, persons with developmental disabilities, and persons with physical disabilities. Well over half, 63%, rated loneliness as less after obtaining the tablet bundle. And we also looked at how frequently recipients were using their tablet bundles, right? So again, you know, we had people, Aging Network and Disability Network providers were referring clients for these devices based on, you know, things that they were recognizing, you know, their care coordinators, their in-home providers, area agencies on aging. So it's not enough to just put them in their hands. So in the follow-up data from the 2078 bundle recipients indicated extensive use of the technology provided. The majority of the recipients, about 52%, reported using the device more than 5 times per week, so pretty much daily. Another 38% reported using the device 2 to 5 times per week, which is still very regular use, while 10% indicated they use the device once a week. In reporting their level of satisfaction with the program, 97% of all recipients reported to be highly satisfied or satisfied with the program. And their gratitude has not gone unnoticed. We received dozens of thank you notes and personal anecdotes from recipients of these devices. And in the interest of time, I'll share just a couple with you. And as you can see, we have some scrolling on the screen to go along with this. So this is not Wanda, but in my notes from Wanda, a senior in Illinois. Thanks to the Illinois Care Connections program, I was able to video chat with my daughter during the holidays. I would not have been able to do so if it wasn't for the generosity of this program. Thank you so much for assisting me during this difficult and different holiday season. Clarence, a senior from from Chicago, said, it is incredibly hard for me to be isolated, but the iPad I received from Illinois Care Connections helps me connect with others. My grandchildren have helped me learn how to use the equipment, and we share our days with each other. This is very new for me, but I've enjoyed learning this technology. Hopefully, more of my friends will be able to take advantage of the program, and we can communicate with each other better. Thank you so much for this opportunity. Oh, this is Wanda. So you just heard, there you go. She just came up on my screen. Clarence's story is similar to many we heard. The majority of all bundle recipients had no prior experience using a tablet that would assist them in operating their device, but they were eager to learn. And stories like Clarence's and Wanda's demonstrate how critically important these tablets have been to people's ability to combat social isolation and remain well during the pandemic. So in addition to the Illinois Care Connections program, the Department on Aging was also able to shift a total of $5 million in resources beginning with its fiscal year 2020 and in fiscal year 2021 budgets to create a new program called Emergency Senior Services, or ESS. So ESS was initiated to address gaps in service as a result of COVID-19. To date, our 55 care coordination units, so these are the entities across the state that help our home and community-based services program, our care coordination program or community care program. They help, manage their care, help them identify services that they need, do assessments about their activities of daily living to see if they need additional in-home services and supports. So they have, so we gave them the grants, they identify the individuals. Have assisted nearly 3,000 unique older adults. So they've done some things like bulk purchasing with these funds, but 3,000 individual needs. related to securing groceries and medication, assistive technology, home modifications, transportation, among many other needs. So when we looked at the fiscal year 21 data, we're working on an update right now, but assistive technology was the third largest out of 12 categories for these individual purchases in terms of the number of individuals served. So that followed nutrition and personal hygiene, which makes sense considering how the pandemic impacted older adults' ability to shop, go out and shop for groceries and personal hygiene items. So, this is one of the many lessons learned that the department and the Aging Network has experienced during COVID. But based on the success of ESS, especially the identification of assistive technology as a need, and the outcomes of the Illinois Care Connections program, the department plans to permanently add assistive technology and assistive devices to the array of services provided for the community care program. So again, that's our home and community-based services program to make sure that people can stay, thank you, in their homes. So I really want to emphasize that we're thinking that beyond the connectivity when it comes to assistive technology, right? We're thinking of the home modifications. We're thinking of those additional things. I see some over there, which is great, to make sure that we can improve people's independence, mobility, address serious health risks, such as falls, and support the unpaid caregiver workforce, which I see in the agenda. You've been hearing about those and topics that we'll hear about later today. So on behalf of the Department on Aging, I really appreciate everyone joining us today. Our Aging Network could not effectively support older adults and persons with disabilities without a broad coalition of stakeholders and researchers involved in this work. So thank you again for being here, and thank you for this time this morning. And I'm looking forward to learning from the other presenters today. Thank you.
So at this time, I just want to give a quick reminder of the overview of our conference and the sessions. So we have 4 different sessions, 3 remaining today. Each session will have 3 presentations with 5 minutes for questions after each, time permitting, and we'll have some moderated discussion after each. It says 30 minutes, but I think it's 10 for each session. Is that correct? Or maybe it's 30 minutes. We'll see how much time we have to discuss today. So for today's morning session, it's focused on enhanced connectivity and community mobility, one of our themes of research for TechSAge. So I'd like to introduce briefly our 3 presenters that we are so honored to have as a part of our conference. First, we'll hear from Katie Perumbeti. She is with the Atlanta Regional Commission and serves as a lifelong communities coordinator. Next, we'll hear from our former NIDILRR program officer, Margaret Campbell, who we're very happy to have join online. She is here representing her own consulting company, Campbell and Associates. And as I mentioned, she is a former senior scientist, planning and policy support advisor for NIDILRR, the National Institute on Disability, Independent Living, and Rehabilitation Research. And finally, we will have a co-presentation from Joy Hammel and Emily Kringle, who are here with us today from the University of Chicago. So to start, it's not time for break yet. We will welcome Katie to the podium. Thank you so much. Okay. All right, you should be good to go.
Perfect.
Huh? I'm sorry. Thank you.
Oh, I don't have my note slides. So I'll go from memory, hopefully. I'm used to the presenter mode. But hi, everyone. Thank you for inviting me here today. I'm actually very excited to go after what we just heard, because a lot of the stuff I'm talking about relates at the Area Agency on Aging level, because I am at the Atlanta Regional Commission. So I'm a little bit different, coming from a different perspective, not from the research side. But I hope to share a little bit more about kind of kicking off why we're wondering about it, or why we care about enhancing connectivity and community mobility, and maybe share a different perspective. I didn't put it on here, but I'm a
my background is actually in city and regional planning, and I'm a member of the American Institute of Certified Planners. So again, I have kind of a different perspective in part of this work. How does it move? There we go. It's just a delay, sorry. Okay, so I thought I would start just kind of grounding the focus today. And again, perfect intro on this, talking about kind of that connection, because when we're talking about enhancing community mobility and connectivity, really it's all about how are we connecting people, things, ideas, whether physically or virtually, with something else. So I'm going to share a quick, it's maybe not news to some of you, but a quick background about where I'm coming from Atlanta Regional Commission, then some of the stats on why we care about enhancing connectivity and community mobility, and then some of the strategies, both low tech and a little bit higher tech. So I'll breeze through this, but I just didn't want to not say where I'm coming from for those of you that are more in the research world. So I'm at the Regional Commission. So we are, this is kind of our elevator pitch. So we engage local government leaders, community partners, and residents to develop kind of a shared approach for how can we improve Metro Atlanta's quality of life. So we are the Regional Intergovernmental Coordination Agency, kind of getting towards that collective impact, realizing that lives don't end at your county line, things like transportation, housing, workforce, all aging, disability services, all kind of span your whole life. We have lots of legal designations. You'll notice one of them is where I sit, the Area Agency on Aging, but we have lots of legal designations, which kind of helps with some of the intersections between transportation group, our metropolitan planning organization. And I'll just note, you probably don't care, but these aren't all the same jurisdiction. Some are 11 counties, some are 10 counties, some are 20 something counties. So for the Aging Independent Services, very similar mission. Our kind of goal statement is to maximize the independence, health, and well-being of older persons and individuals with disabilities. So how are we doing that here in the now with some of these home and community-based services, but then also how are we thinking about the future? So we're part of, again, this aging network. So I'm just one step down at the Area Agency on Aging level. But within our Aging Independent Services group, we're a little bit more than only the Area Agency on Aging. We do a lot of planning work. So how are we thinking about our, we have very fast in Metro Atlanta, those of you that live there might know this, might not, but we are one of the fastest growing older populations. A lot of people moved there and then didn't leave. So we have a very aging cohort. Then also how are we providing services, whether it's directly or with partnering with our county agencies or specialized providers, and then a lot of policy and advocacy. This is just consumer facing. We're known as Empowerline. All right, that's the background. Breeze through that. So into kind of why community or connectivity and mobility matter. And I hope that I'm not preaching to the choir on this, but you all probably know we're all living longer, healthier lives. Median age, this just shows that 1970 to 2040 in the Southeast, around the US, Georgia. I mean, everywhere, wherever you look, everyone's kind of aging older. And it's a worldwide trend. This is from Gap Finder, if you've played on that website. This is countries around the world. I think the captions are blocking it, but it's births per woman on the bottom and life expectancy on the y-axis. So countries as a whole, if I were to play the video, they start over here and they all go that way. So if you think about the implications for that, when you have fewer caregivers, you have families that are people not having families, and we're all going towards that longer life expectancy. In the United States, you see that age, this kind of that traditional population pyramid, but even in the past 10 years, you can see kind of our population pyramid, the older or the younger ages shrinking, and the older populations making up more. So again, just kind of the aging overall. You've probably seen this stat a million times, but by 2040, projections are that a quarter of us will be over the age of 65. And then when we're thinking about disabilities, so including cognitive disabilities and as well as physical, a quarter of adults in the US currently have a disability. Again, preaching to the choir here, probably. And the 2 in 5 people ages 65 and older have a disability. I just threw one in here that a lot of us can relate to. And actually, we talked about this yesterday, a few of us. But this kind of surprised me. If you think about it, at least half of us, once we reach age 65, are at high risk of developing a visual impairment. Another thing that, this is an older statistic, but I'm sure it still holds true, maybe even has gotten longer, but a lot of us are outliving our ability to drive. So when we're thinking about how are the people outliving their ability to drive getting around, they're relying on public transit, they're relying on specialized service riders, they're relying on their adult children, their neighbor, their friends. Sometimes this doesn't respond to me. Oops. And then again, this is kind of repetitive of what was just shared, but for those of you who don't know, I mean, the social isolation and loneliness are rising. And this is a phenomenon that's happening in the US, UK, I mean, it's happening everywhere. But I think it's important, those of you unfamiliar with kind of this conversation, that there's social isolation, which is objectively being alone. So how can we get people not to be objectively alone? Then loneliness is a subjective feeling. So that's, how are you creating connections? I mean, you can move people about, but how are you addressing some of that subjective feeling? And I just threw in a few different recent, it's just showing quick impact of the pandemic, and it was early pandemic. So I'm not sure how those numbers will have shifted. But Americans are reporting feeling lonely more often, or at higher rates than before. And then this is AARP compiled a report about loneliness and social connection, and just looked at lots of facets of people's lives and what's driving some of their isolation and what's their feelings of loneliness. But even things as simple as talking to a neighbor, if you haven't done that, you're twice as lonely as those who have. And again, the health effects of this prolonged isolation have been found to be equivalent to smoking 15 cigarettes a day. There are a lot of underlying effects, obviously a lot of mental effects, but that can lead to depression. It can lead to higher levels of stress, anxiety. It leads to higher rates of heart disease, stroke. I mean, it really gets into your physical psyche, or your physical everything, as well as your mental, and has really devastating health effects. So who cares about mobility and connecting? There's a long list. I started to put together a list, and then I was like, wait a minute, it's bikers, walkers, toddlers, people pushing strollers, in addition to the people that everyone here is focused on, which people with disabilities, older people. So really it's everyone. Everyone really needs our mobility, needs to be able to connect. So the perspective that a lot of the work my agency does and myself really frame it around lifelong communities. So all people need these lifelong communities, thinking about how are we being connected to where we live, our stores, our services. And I think before the pandemic and with the pandemic especially highlighted that physical and virtual, I mean, we really are looking at both. So moving into kind of more of the time, some of the strategies to enhance connectivity and communicability. So I think the top point is really the way that our systems, the way people are aging in our communities, it's not really designed in a lot of ways to enable community living. I think one of the good things come out of COVID-19 is it highlighted how home and community-based services are usually a lot more preferred and also a lot safer. People are living longer than if they're in nursing homes. So how are we designing our systems to enable that living in community with programs like delivering tech bundles? We all need safe gathering spaces to reduce our social isolation. And again, that internet connectivity is becoming more of a thing. So trying to bring it back to kind of the mobility space, the transportation space. And when you're thinking about all travelers, both outdoors and indoors, we all want the information to be complete and ideally clear. And then also origin to destination accessibility. So a lot of the transportation systems that have been designed and technology is really focusing on, well, previously more kind of that door to door, but we really need to think about the origin to destination, indoor and outdoor. And then also coming from a caregiver consideration, whether you're a caregiver for an adult with disability or even a child. I mean, you want to think about how can you manage some of these things, remote monitoring, trip status. So before I go into kind of the tech side of things, some of the planning solutions that in kind of the governmental city focus on is how can we prioritize our services where older people, and I put an asterisk because it might depend on your community what you are focusing on. So it might be that you low income or individual disability, kind of specific to your demographics, but where are clusters of people living and lacking options and how can you prioritize service? So an example there is we have a city in our metro region that has a little circulator bus that operates for I think it's 6 hours, a couple days a week, and it picks people up where they're from a few different senior high rises, but also some of the older neighborhoods that people have lived in for a long time. It's just a circulator shuttle that goes to their active living center, a grocery store, and the CVS shopping center, and then back. And it's, so how are we thinking about prioritizing services like that? Designing, accessible, specialized drop-off and pickup points. And then I think a really easy planning solution for enhancing our mobility in our communities is we might have existing options, but are people using them, and why might they not be using them? So basic things such as lighting and lack of shelters and lack of sidewalks to a transit stop, if we're speaking transit, ramps and curb cuts. I mean, someone with disabilities not going to want to, if there's not a curb cut to get off the sidewalk, but the street's not safe, well, then they're just not going to leave. There we go. Programmatic solutions, thinking about travel training. Is travel training a common thing people are familiar with in this group? So travel training is often the travel trainer will train either one-on-one or in a group setting, someone who is maybe older, has a disability, who's not familiar with the transportation system, and they will, as long as it takes, sometimes it's one session, sometimes it's multiple sessions, but go everything from starting of this is how you map out a trip on the public transit station, and this is how you use it. And they will literally ride with them to like from A to B to show them how to use it. And so that really, we actually use volunteers through AmeriCorps Seniors to do some travel training, and it has high success rates. When people just know how to use the system and have that confidence and have done it a few times, they'll start using it. Not everyone, but people will once they understand all of that. And then also thinking about how can we design new or expand some of our existing services. So volunteer driver programs, voucher programs, so reimbursing for gas for somebody to provide a ride. And then even thinking about our bike share in our cities, which is kind of, it depends on your city if that's still a thing or not, if it's kind of flowed with scooters and all that. But can we add e-bikes to those systems? I know Atlanta added some e-bikes to their bike share. So it makes it a lot easier for someone that might not have the same fitness level to get around. And then of course, programmatically to train your transit operators to provide appropriate assistance. So especially if someone perhaps has low vision, to train a transit operator to help that person get on the bus, to help them find a seat, that sort of thing, to make sure that they're aware of how to provide appropriate assistance. So this is really preaching to the choir here, but when we're thinking about, especially in really in any space, when you're designing with and for someone with disability, everyone's going to benefit. So I put some larger scale things in here that I appreciate in my day-to-day life. So automatic doors. So you don't have to, I mean, a lot of you might be staying in a hotel. You can roll your bag in without having to deal with everything. I have little kids, so if I'm pushing a stroller and I reach an intersection and there's no curb ramp, I have to lift the thing down. I mean, everyone wins. That wasn't necessarily designed for me, but thinking about how can we really, for someone without a disability, it makes life easier. And I mean, for someone with disability, it makes life possible. And we're thinking about some of the technology-based solutions that colleagues of mine are working on at ARC, as well as all of you and others researching, they really are a complement to some of these planning and programmatic solutions. So I heard someone recently say that disability is often a consequence of the environment. And that really made me think, I mean, the person uses a wheelchair and they were saying, I a lot of times don't think about the fact that I'm using a wheelchair till I get somewhere and I can't access something. So thinking about it from that perspective, I thought was interesting. And it also, from some of the conversations yesterday that you were here, just kind of that we operate from a deficit-based approach in a lot of our things, and why can't we kind of flip that on its head? So some of the technology innovation examples that I have a couple slides about is indoor wayfinding, automatic vehicle shuttles, and ARC, some of these ARC projects I'll share about, and these are really focused on kind of that transportation. I sort of thought about putting in some of our connectivity solutions, but from a connection that are low tech, like we have a one-to-one phone calling program, but these are more kind of the technology side of things. So I'm assuming a lot of you might be familiar with indoor wayfinding, but there are lots of companies coming out with kind of this technology. So a lot of times it's a Bluetooth beacons that you place around different areas so that someone can have on an app on their phone, they'll get turn-by-turn directions. A lot of them have the ability to define, and it's usually for a large public space. So it would be for a hospital, for example, or like a large public transit station. And you can define the custom routes for people with reduced mobilities. You can show points of interest on the map. And then automated vehicle shuttles, I'm really curious to kind of see how this evolves. So there are lots of potential uses, but a couple examples here. There's a Detroit hospital, and I'm blanking to my notes on the name of the hospital system, that actually just started like a year and a half ago, an AV shuttle that goes around a neighborhood that transports older people and low-income people to their appointments, because a lot of people were missing appointments because they lacked transportation. Another use is, using an AV shuttle around retirement communities or continuing care communities for people who, well, especially if you're in if the climate and you don't want to walk, or also if you have reduced mobility. I think I put a couple points on here, some of the kind of equity side of this that really need to be considered in a lot of this AV stuff is, how are people scheduling this? How are people seeing when it's coming? A lot of it relies on technology. So that smartphone and internet access, especially if you're in a more rural area too. And then again, obviously the accessibility of vehicles. And if it's driverless, how are people getting on and off, and what happens before and after the curb? So yeah, I think I still have time. So I'm going to share about a couple of ARC projects. So the first one is part of the It's For Us deployment program. That is it's a multimodal deployment program. There are 5 different awardees around the United States. And so the idea here is, how can we innovate to provide, well, the vision is covered up, but how can we have complete trip deployments so that it's seamless travel for users to get through all of their modes, and it's really focused on kind of that origin to destination, regardless of their disability status, their location, their income. So ARC is one of the awardees. Our project is known as Safe Trips in a Connected Transportation Network. So kind of the goal here is to have a connected, safe network that's focused on these listed underserved communities of interest, developing a route based on people's specific needs. So yeah, I won't read all these. Walking speed for signal is sometimes handled by planning, by just making the signal crossing longer, but how could you use technology to actually change the signal to go? And really, again, the project goals are to enhance the complete trip experience, enhance the safety and reliability of these. And really, just in the day, we're all trying to move people around, because connected people are happier and live healthier lives. So I won't read all these, but so in the phase that is wrapping up now, this project have done some extensive stakeholder engagement with different partners in the Atlanta region, including our Center for Pan-Asian Communities to think about other non-English speaking populations. I believe Tools for Life might have been listed as a partner. There are lots of them, the State Independent Living Council, lots of stakeholders have helped kind of gather what are the needs from start, or not even start, like the planning phase to the end phase. So some of them listed here, but a lot of it around how can I customize my trip to my abilities? How can I get alerts that I'm able to either are they audible alerts or do I want written alerts? How am I able to get alerts? So I won't read these. The indoor navigation came up a lot of, okay, I get there, how do I then get around? So this is kind of the deployment concept mapping that they've come up with. So starting at the pre-trip planning, some of those things I mentioned, the transition to transit. So if someone has some sort of ability or reduced mobility, they would know, the transit operator would know in advance. Intersection crossing, so a signal controller, oh, actually it's in the CD broadcast. So broadcasts of, say someone, it's a hot day, like you can literally speed up, give signal priority to buses and speed up the bus coming through to reduce the time that person's waiting outside. So this is the concept. And the way the technical approach to implementing this, we have a lot of existing programs in our project area, a lot of existing data sets. Some of the challenges with this technology is how do we integrate them so that they speak to each other, and how do we get them in the same, speaking the same language? And that's all IT stuff that, let's see. Okay, so this is where the development phases are in. So a lot of it's just the concept development, and this is all the 5 awardees around the US are just wrapping up their concept development and moving into the actual design and testing. So that'll be a 2-year phase. So actually finding, creating these systems. One more ARC kind of mobility project is the Transit Planning for All grant. So it's through the Community Transportation Association of America, and it's a partnership with, so it's focused on a region or a smaller geographic region in Gwinnett County. So it's a partnership between several providers, again, including the Center for Pan-Asian Community Services, the Gwinnett County Transit Center, Shared Use Mobility Center, and Statewide Independent Living Council. So this project, it's similar, it wants a mobility on demand solution. So being able to have it geared towards older people, caregivers, and people with disabilities. And with the partnership with CPACs, they're really targeting limited English proficiency individuals in the design of the solutions they're working on and the implementation, with the idea that if you can make it work for kind of the most vulnerable of the transit users, it'll scale it up to more people. So some of the challenges they're trying to get at is that right now, CPACs is manually scheduling trips. They're having to conduct that travel training with their riders on how do they get from maybe a CPACs bus onto the public transit bus. And then also providing these translators to help communicate with the transit operators at GCT, which I would also argue you could train some of the GCT operators a little bit better on accessibility. But then also thinking about kind of the micro transit, some of the equity considerations they're trying to address with the technology they're developing is how do you make it work for someone who doesn't speak English. And then also another thing always comes up, and it's probably a national thing, but every time we talk about these projects in our region is how do we deal with people who don't have access to internet or smartphone, and how do you deal with fare payments for unbanked persons? Because if you're doing this all through online, how are you paying if you don't have a debit card? So this project is actually in the phase of, we have a technology firm developing the solution now. So we've already done a lot of upfront designing community engagement side. But some of the anticipated hopeful outcomes are to improve kind of that operation between the CPAC's transit fleet and the coordination with the Gwinnett County Transit, having better trip coordination with those, and then also two of the things they're trying to really document and think or establish this framework for how are we engaging the communities equitably for future projects when we're designing, when we're developing what we want to do. And some of the future uses that got covered up on the bottom there is on-demand meal delivery, medicine delivery, etc. So with that, yeah, that is all of that. I don't know if I do questions now or later. Or, okay.
I need to turn on our microphone for our any questions that we have. Hopefully we don't get feedback.
Testing. Thanks, Katie, so much. Again, this is Amy Lulich with the Illinois Department on Aging. So one thing I have, and I was taking a lot of notes because I always want to be able to give our AAAs information and share that. But with the this transportation pilot, you didn't say anything about safety. And I'm talking about safety not only from, similar to Georgia and Atlanta, I'm sure, city of Chicago, we have, a lot of safety issues and concerns in different communities and different, levels of safety and amongst communities. So you didn't mention anything about that.
Yeah, I think I probably breezed through it. So one of the pillars of the connected safe trips in a connected transportation network is how do we have safety in there. I can't remember how they phrased it, but that's one of their considerations of from a the crossings, the traffic signals, the heat, the safety from all over. If you're talking about safety in terms of crime and things like that, I don't know. I'd have to ask the project coordinators. I guess that's always a risk you're going to have when you're using transit and all that. But unless you mean crime on the buses.
Well, I guess I would say both.
Yeah.
Not to be alarmist, but there's a big heightened awareness, especially in the city of Chicago, about increasing crime on our transit system.
On your transit systems.
Yeah.
That would be an interesting question that I honestly do not know the answer to, because a lot of the networks that they're utilizing are our existing transportation networks. Obviously, for things like some of these specialized fleets and the paratransit services, that would be a little bit different. But in terms of a lot of this is tapping into our MARTA network or Gwinnett County Transit. I don't know that they're thinking about crime, safety, modifying any of that. So that's a good point to kind of bring up to them. I don't know. Now you're asking. I'm thinking of questions to ask them. I don't know if
because autonomous, so there's no driver, correct?
Right. So we aren't working on the autonomous vehicle side. Those are just some of the examples, but that would be a good, the Detroit one, that shuttle. I'm not quite sure on the details on how that's working with the hospital system, if they have a rider on it.
Right.
I do know some shuttles in Atlanta, I don't know if anyone rides it, but the streetcar has a person that is on it, that even though they're not operating it, they're on it. So it's kind of like a monitor. But yeah, that's a great kind of for the implementation when they get to that build out. How are they? Cameras. I'm assuming all MARTA buses already have cameras. I don't know. Yeah, that's a good question. We're never going to be able to solve for it standing on the street corner waiting for your bus and that sort of thing. But I think from their safety, when they're saying enhanced safety, they're thinking more from the how can we make sure their transportation safety and health, personal safety from not being in the outdoors and stuff.
But I do think that some of the technology like tracking, for instance,
Yeah.
if you can in real time see where the transportation is, you can time it better so that you're not waiting as long. The longer you wait, the more likely you are to have a crime
And part of it too is that how do you have the interface that I kind of, sorry, tried to put a lot in, so I breezed through, but how from some of those caregiver considerations, how are you helping to monitor the trip as it's happening? How can you monitor, because the person has their phone that's using it, so how can someone, a caregiver, also see where their person is, which is already possible with Share My Location, I guess.
Right.
Thank you so much, Katie. So at this time, I want to check with Margaret Campbell to see if you are on the line.
I am. Can you hear me?
We can.
Great, great.
Let me see. Give me 1 second. I want to be able to see your face. If you could help me with that, Alyssa. It takes a village to do tech support for these conferences.
Right. It certainly does. Oops, all of a sudden I lost you.
Margaret, would you like us to share your slides?
All of a sudden I lost you. Yes, please do.
Okay, let me pull up your slides. And are you able to, let me share screens again. So how do I do it with both?
Let me get. Share the screen.
There we go. Yes, I see my slides now.
There we go. That's what we need.
Perfect. So please just tell me next slide and I will advance for you.
Wonderful.
Hear
Thank
you
you,
loud and clear.
Elena. Okay. Good morning, everybody. I'm delighted to participate in this wonderful State of the Science Conference, and even more delighted actually to see all the progress that what I call this gang of four, by that I mean John and Wendy and Tracy and Elena, have made over the past 10 years under the TechSAge program. It's very impressive. So thank you for including me. This is an interesting juxtaposition of presentations because you got a more local and micro look at transportation programs. And now we're going to go back up to the macro level for a while and look at federal transportation policies and programs for adults aging with disabilities and look at some of the complexities, gaps, and implications for community mobility. So next slide, please. I want to start by acknowledging that the content of this presentation is taken primarily from a recent publication that I was honored to be the co-author with under Elena, and it was recently published in the Disability and Health Journal and is available via this link. Also, of course, we acknowledge TechSAge because this research was conducted under TechSAge, and as you know, it's funded by NIDILRR. So those are acknowledgements. Okay, I have three objectives today. I want to provide this overview of the federal context of transportation policies and recent initiatives targeted on what is called transportation disadvantaged populations. And I want to highlight some of the complexities and gaps within these programs, and then present research results from a mixed method study comparing barriers to implementation of federal transportation programs to the transportation challenges reported by persons aging with mobility disabilities. Then I want to close with hopeful new funding developments under the American Rescue Plan Act. So let's start off. Let's set the stage. You've probably heard a lot of these statistics already. This is just to galvanize us even more and provide those statistics to document the critical importance of transportation to this target population. So we can look at how many older Americans have travel limiting disabilities that make it difficult to even leave their home, 11.2 million. We know that mobility disability is the most prevalent type of disability among older Americans, affecting over 15% of those in the youngest group and up to 48% of those 85 and older. We know that Americans with mobility disabilities rely primarily on personal vehicles, either as drivers or passengers, with low utilization of public transportation, paratransportation, or taxis and rideshare. This low use of public transportation has been attributed to a range of personal and environmental factors, such as difficulty walking, inaccessible vehicles and facilities, restricted services. We've heard detail about a lot of this, and we're going to add more environmental factors to this list through this presentation. But the bottom line is that a lack of access to adequate transportation can and does hinder the ability of older adults with mobility disabilities to fully participate in society. And this is what, of course, motivates all our work, and this is why we're here. So let's go on and look at the federal context. Next slide, please. Here there are two main pillars of the US Federal Transportation Civil Rights Network. Of course, we start with the Section 504 of the Rehabilitation Act, which protects against discrimination by reason of disability under any US Department of Transportation conducted or funded program. Then in 1990, we get the Americans with Disability Act, which expanded the Rehab Act. It expanded it by expanding protection from discrimination to all public entities that provide transportation services, whether or not they receive federal funding. It expanded the types of transportation systems covered, as was illustrated in the last presentation. And it broadened the reach of accessibility requirements also, as illustrated in the last presentation. So those are our two pillars for a transportation civil rights framework within the US. So let's now look closer at recent federal transportation initiatives under the FAST Act. The FAST Act refers to Fixing America's Surface Transportation. It was signed in 2015, went into effect in 2015, and it authorized $305 billion over fiscal years 2016 to 2020 for highways, vehicle safety, public transportation research, technology, and statistical programs. Its significance is that the provisions under public transportation, specifically Section 3006, represented the first federal legislation in over a decade to provide long-term funding and infrastructure planning and investment to address the lack of access to reliable transportation experienced by millions of transportation disadvantaged Americans. And this was defined in the law as older adults, people with disabilities, and low-income individuals. The key programs under this section 3006 are listed here, and those key programs under under this section were funded at $50 million initially. And if you look at that in terms of the total investment in the FAST Act, that's about 0.005%. Those three programs include enhanced mobility of seniors and individuals with disabilities. This is a formula grant program available to states and tribal organizations to assist nonprofits in meeting the transportation needs of the target population. Then we have the Program for Innovative Coordinated Access and Mobility, otherwise known as ICAM. These are competitive grants to states and local agencies and service providers, like what we just heard in the last presentation, to foster partnerships among health, transportation, and home and community-based services. And third, we have the Interagency Coordinating Council on Access and Mobility, known as CAM. This is an infrastructure that was created to support federal interagency efforts to implement Section 3006 requirements. So that's basically the structure of the FAST Act as it applies to older adults and people with disabilities. So now we're going to look a little deeper into these programs and see what their features are and point out some of the complexities and gaps. So starting with the enhanced mobility for seniors and individuals with disabilities. Remember, that's a formula grant program to states and organizations. The good news is that the funding under Section 3006 was supplemented with funds from another title program, Title 49. And so funding levels ranged from $258 million to $285 million per fiscal year across the FAST Act. Funding was based on a state's share of older adults and people with disabilities, and of course varied by rural and urban areas. Another benefit of this program is that matching funds could come from non-DOT agencies. So they could bring in matching funds from HHS or from any other non-DOT federal agency. So what about the types of investments allowed? Two categories of investments. The traditional investments required that 50% of funds must be used on capital projects. We heard examples of this just previously, but a wide range of capital projects were allowed, wide ranges you can see listed here, from vehicles of all kinds to wheelchair lifts, to information management systems, to mobility management programs, as we saw illustrated, to acquisition of para-transportation services. The non-traditional investments, 45% of these funds were for other projects beyond those required by the ADA. So this went even beyond the ADA. And we just heard a lot about travel training programs, volunteer driver programs, accessible paths, curb cuts, improved signage, and wayfinding. All of this was allowed under this program. So what were some of the gaps and complexities? Well, the funding formulas and requirements are indeed complex. I can attest to that. It took me weeks, literally, to ferret out all these provisions and to document them and try to map them and get and understand them. So that's a major complexity. The other one is that states and tribal organizations are required to have matched funding from a federal agency, and that's difficult for many states and tribal organizations to achieve. So the second program then, let's look at the second program, ICAM, which again is a competitive grant program. Under this 4 years of the FAST Act, only 51 grants were awarded, and the funding levels ranged from 3.5 to 7.3 million per year across these 51 awards. Two examples, Mobility for All pilot program, which was to enhance the connections to jobs, education, and health services for the target populations. And then Rides for Wellness demonstration, which was to foster local partnerships, to support increased access to healthcare, as well as improved health and reduced cost. Here, the gap is obvious. This is a small number of grants awarded across the United States and across 4 fiscal years at pretty low levels of funding. So the third program we're going to look at, next slide, again is CAM, or the Interagency Coordinating Council on Access and Mobility. And this was funded initially by member agencies out of their own budgets. And the membership included the agencies listed here, which you would expect, most of the federal armament here, but it also included the National Council on Disability. Allowed activities, they focused primarily on issuing policy recommendations and implementing activities that improve the availability, accessibility, and efficiency of services for transportation disadvantaged populations. 2 examples include the creation of the National Center for Mobility Management, which also awarded grants to support mobility management professionals in adopting proven, sustainable, and replicable strategies. They're trying to get the adoption and translation of these strategies into the local and state levels. Second one was the National Aging and Disability Transportation Center. Again, awarded grants to support communities to assess transportation needs and develop and implement innovations. So what are the gaps and complexities here? Well, really, initially very limited funding to support this wide-ranging and ambitious set of implementation activities. Huge array of activities were created under this with very little funding. There was also minimal to no involvement of state and local agencies, service providers, and end users in the policy development of CAM and in the implementation strategies. It was all basically federal. Let's go to the next level. Okay, so with that as the context at the federal level, the macro level, we're going to look at results now from a mixed method study. And here we're going to be looking at the comparison of transportation barriers and challenges from 2 sources. On your left, we're going to be looking at barriers to implementation of transportation policy and programs experienced by service providers. This is from the CAM program. On the right, we're going to be looking at transportation challenges reported by people aging with mobility disabilities from the Access study. And both of these 2 studies or programs were conducted within the years of the FAST Act, and their data collection efforts were very similarly timed. So moving on to the next slide. What are our data sources? Under the CAM program, we have 2 data sources. A 2018 focus group study, which was conducted by DOT, with 200 transportation and human services stakeholders representing 22 states. And then we have a 2018 nationwide survey on transportation coordination, best practices and barriers conducted by the National Center on Mobility Management, which involved 527 transportation and human services employees across 47 states. For the access study, you're probably familiar with this study. It's a regional TechSAge project and a regional survey of individuals who self-identified as having a mobility impairment prior to age 50. And the survey asked about the frequency, nature, and distribution of problems in everyday life, including transportation, and the response strategies for these challenges. The resulting sample included 60 respondents with an average age of 69, age of onset ranged from birth to 49 with a mean age of 19 years. And the top 3 primary sources of mobility disability were polio, neurological diseases, and congenital conditions. Those are our data sources. So let's look at some of the results. So on the CAM side, we have the top 10 barriers to transportation coordination reported by state and local stakeholders. So these are listed in rank order, starting number 1, right at the top, limited awareness of federal funding sources that are available to human service transportation providers, and lack of awareness of the policies that enable transportation coordination and support community options. Huge barrier, and it's right at the top. Second, unengaged stakeholders. It's challenging to establish and maintain organizational and community partners, such as the excellent ones we just heard about, with unengaged stakeholders. Program restrictions, a host of program restrictions, everything from differences in eligibility criteria, trip purpose restrictions, and lack of reimbursement arrangements that make it difficult to coordinate access across different transportation programs. Insufficient financial incentives and the required matching. So insufficient incentives for human service providers to pursue transportation coordination initiatives, and also to get access to the required matching funds. Number 5, limited federal guidance, an absence of federal guidance that states and local communities need to coordinate transportation in compliance with federal law. And the list goes on. In the next slide, we see jurisdictional boundaries. We all know about these jurisdictional boundaries that prevent organizations from coordinating across these boundaries, and of course, result in boundaries for access to services for end users. Administrative burden, many administrative burdens, reporting, logistical responsibilities, et cetera, which consume an excessive amount of time and resources. Insufficient data, I found this one very interesting. A lack of data being collected that states and local communities need to increase the transparency of transportation spending and demonstrate the utility of transportation coordination. Apprehension about cost sharing. How do you do it? How do you do it equitably and proportionately to the services received? And finally, all these barriers translate down to the bottom line of inaccessible systems and lack of accessible transportation that state and local agencies and service providers have to meet the needs of people with functional limitations.
Margaret, I'm sorry to interrupt, but we're nearing time. If you could take the next minute to wrap up.
Wow, okay. Next slide, okay. So here we're going to look at the correspondence between these state and local barriers and end user challenges. So on column A, you have those 10 barriers again, and column B, you have the transportation challenges reported by people aging with mobility disabilities from the access study. And as you can see on the left side, column A, all of those barriers interrelate to each other, and they culminate, as I said, in inaccessible systems and lack of accessible transportation. And all that relates to the number 1 challenge on the right-hand side, the shortage of accessible transportation options at both the public level and the private level. Also translates to inaccessible transportation features to support transferring and more than one wheelchair per vehicle. It also translates into financial costs and affordability, another challenge, and to the amount of advanced planning and waiting required to access transportation services. So there's a lot of correspondence between this state and local, what state and local agencies and service providers perceive as the barriers and what end users report as their challenges. But interestingly, there are three that I highlighted in yellow, which are not reflected under column A. And we just heard about the lack of concerns for safety of end users, the physical limitations and health concerns of end users that challenge them in accessing transportation, and also their experience of societal attitudes on the part of providers that reflect ableism. So moving on, quick, we have three summary of findings. What's going on at the federal level, this intractable array of complex and inadequately funded formula and competitive grant programs. We have the results from the mixed method study, which strongly suggests that these complexities and gaps at the federal level contribute to the barriers reported at the state and local levels and to the challenges reported by end users. So together, these findings highlight the critical importance of increasing funding levels and reducing administrative burden, of creating more robust implementation mechanisms, such as federally funded navigation systems that really serve to improve outreach and guidance for stakeholders. And of course, including input from all stakeholders in all stages of transportation policy and program development and implementation. In short, there's much to be done. So in the last slide, I want to end on a more positive note. In closing, there is hopeful new funding under the American Rescue Plan Act of 2021, which includes additional funding for some of these programs. Another $50 million under the ICAM program to continue improving transportation coordination and to reduce overlap among the CAM programs and incentivize collaboration, and an additional $2.9 million under the enhanced mobility for seniors and individuals with disability programs for formula grants to states and local and states and travel organizations to assist nonprofits. So stay tuned. We're hopeful that this additional funding will indeed make a difference and continue to formalize and implement a lot of these innovative programs that you heard about in more detail previously. So with that, I'll close. Thank you.
Thank you so much. So we'll have to save questions for our discussion period for the sake of time. So please hold on to that and we will come back. So at this time, I'd like to invite Joy Hammel and Emily Kringle to co-present. Thank you so much, Margaret. We appreciate you being here. And it's not a shameless self-plug, but please take a look at that paper. It's available online. Margaret put a ton of work into organizing these resources. They are not easy to find, and it's in a great package and very useful resource. So thank you, Margaret. Okay. Let's see if it clicks correctly. All right, we're good to go. Thank you. Always hide the bar. Thank you.
We're usually looking for the bar, but today we're.
All right, you're good to go.
All right, thank you. And thank you for the invitation to this TechSAge conference. We're excited to be here. And myself and Emily Kringle, my co-presenter, would like to talk about, in this case, a research project. So we started at the state and local level on policy and system implementation. We went to the federal level. And now this is an actual research project on working with older adults with disabilities on how to actually make it all happen, right? To actually make it so that they can actually get around in their communities and participate along with that. And I would like to, first of all, acknowledge two of our co-investigators, Dr. Beth Skidmore at University of Pittsburgh and Dr. Carolyn Baum from Washington University. Let's see if it actually goes here.
The arrow keys.
Yeah, right and left. Oh, up and down.
Oh, let's try this again. It's always something.
And as we're doing that, I'll just continue right along. And in terms of acknowledgements, I did want to acknowledge that this research has been funded through a clinical translational science pilot grant that lets you work across different universities and across different research projects to evaluate new programs. And that's NIH funding.
Should be a click.
Click.
Yep,
Excellent.
there you go.
Perfect. And then I also wanted to acknowledge that Dr. Kringle has come through both two different postdoctoral programs, a NIDILRR funded postdoctoral program on participation, and then an NIH Department of Medicine postdoctoral program. And she, I'm happy to say, is now moving into an assistant professor at University of Minnesota right after this presentation. So just to situate us, I want to start, first of all, why did we do this research, right? So first of all, there's research we've been doing for years with people with stroke and in fact, people with disabilities in general as they're aging. But there's also a compelling body via NIDILRR of longitudinal studies of people and what happens as you're aging with a stroke or a disability. And some of the issues that we're seeing in that research is, first of all, people are living with disabilities and chronic conditions long-term and multiple chronic conditions and disabilities. They're facing and reporting significant participation restrictions, and in fact, actually significant participation complete loss is what we're seeing since a stroke. They've given it up. And talk about that these things aren't focused on during rehabilitation at all for them. And these include issues with social isolation, loneliness, participation, and social networking and support. And now even more than ever, virtual networking and support as well. And result in decreased physical and mental health issues as well. We also know from the research that all of these things are more likely to occur in people from underrepresented groups who have a stroke, especially people by race and ethnicity, so people who identify as African American or Black or Latinx, which are the groups we've been working with, and by income levels, people who especially identify as living below poverty and in low income, which is the other groups that we work a lot with. So how did we get to try to address some of those issues? We brought together two very different research camps from 3 different universities that have completely different funding sources because we each had pieces of the puzzle here that we wanted to work on. So first of all, Dr. Beth Skidmore at University of Pittsburgh and her team has been funded through NIH, has had a series of R01 studies through NIH and NCMRR, looking at developing an individualized guided discovery strategy training program for people with stroke, and has delivered that as part of randomized controlled trials, both in acute care and inpatient care. And what she found is indeed this individualized strategy training worked for increasing people's everyday functional engagement across all different activities. And she also found that it helped to decrease some of those emotional and physical symptoms, right, that were going along with it. But what she wasn't able to show is increased community participation and social participation. And that was a gap. Whereas on the other hand, we were doing research between Chicago and St. Louis as part of the RRTC on stroke, NIDILRR funded, to look at developing and testing a social learning self-management group-based intervention where people with stroke get together and support each other and work through how to do these things for participation. And we tested that post-rehab in the community long-term after stroke, right? Many years, in fact, for some people after stroke. And we were able to show in a randomized controlled trial that not only could we could increase community participation and social participation, but what we couldn't show is that long-term activity engagement that Beth was able to show, on a daily basis, how frequently, how often are you continuing this over time, right? And so we said, what if we bring together these two theory-based and evidence-based, in this case, approaches, and try to get at not only activity engagement, including community mobility management as one of our primary activities, but also full and equitable participation in society, right? And when we say that, it means a lot more than how often do I do something. It means issues related to choice and control, access and opportunity in that society, and importantly, social connection, inclusion, and membership, right? Were all the kinds of things we were focused in on. We also wanted to create an intervention that was responsive to the chronic care model, right? That so much shows that the vast majority of the populations, aging and disability, are out there post-acute trying to live with multiple chronic conditions long-term, yet we have much fewer supports available to them, right? So we wanted to do a community-based intervention that would be something that could be implemented, say, from the area agencies on aging or other places in the community to be able to address those needs. And we created something called Engage. And got a pilot grant, NIH pilot grant, to be able to test this. So what is Engage? It's a 12-session intervention. In-person intervention is what it was designed for. That includes self-management, social learning groups where people with stroke are getting together with each other to problem solve, goal set, work through their own personal goals, but share strategies and support each other. So they get a social network at the same time that they're doing that. And it was coupled with that guided discovery from Beth's group, the individualized strategy training that we did on top of it, and took them out and actually pursued their goals. So there's at least 4 sessions out in the community, real-time goals, real-time strategizing them in the community. It works on a process of goal setting, problem solving, action planning that is very client consumer directed, right? It is not a cookbook approach to doing it. You set your goals and instead we teach you a process for problem solving. And the content was focused on the areas that people, in this case with stroke, but we hear it repeatedly from older adults and people aging with disabilities, on things they wanted to most address. And that is, people wanted a forum to even talk about disability and the stroke experience and what the impact. They felt very isolated and lonely in dealing with stroke. And they also wanted to actively work on community participation, home, just staying in your home and participating, getting out into health and fitness in the community, and then importantly, civic engagement, volunteering, and anything social was on the list. And I could say it meant even just getting out and about and going to Dunkin' Donuts and being able to people watch, right? That they had given that up. The intervention is co-facilitated by a peer facilitator with stroke, e.g. a peer mentor from the stroke community and an occupational therapist. And it's delivered in community neighborhood settings, e.g. your local Y, a community center, a church basement, you know, whatever works for the community. Now, halfway through our pilot project, COVID hit. And we had 2 choices. We could either stop it with a much smaller population in the pilot, or we could use the money as a feasibility project to transfer the whole thing to online and Zoom and see what happened, right? And do it as a feasibility pilot. And our funders and the community of stroke survivors that we were working with that were informing us said, oh, do it. Like, it is incredibly important right now. And so we did it. In terms of just some preliminary findings, and these are hot off the presses because we're just about to put these out in articles. We're submitting them as we speak right now, and submitting for bigger randomized controlled trials on this as well. Preliminary findings are, we did have 31 participants that helped us to do this pilot feasibility study. On average, 61 years, although there was a range. So definitely an aging with disability population, right, that we're experiencing. You can see a lot of comorbidities at the, at least 6.5 chronic conditions or disabilities at the same time. We were able to have 42% of the sample identified as African-American or Black, over 80% of the sample identified as living in poverty. So we did have a low income living in poverty, and time since stroke, at least 4.5 years since. So it definitely a community-based sample. What do we show? Feasibility, high attendance rates, 92 to 94%. Something about this really worked with people, and they came back again and again. They addressed a lot of those goals we talked about right at the front on participation, particularly in the areas of community leisure, home leisure, and social. And just a note, community mobility and transportation management were almost in every single goal. It was just a sub-step to be able to get to participation. And we were able to show some significant increases in these areas on a pilot basis, right? So we were able to show more engagement, more actively engaging in the community over time and more frequently. We also were able to show an increased confidence and self-efficacy in managing that community engagement and all the environment around it to be able to do it, as well as social and recreational, as well as advocating for resources and your civil rights to be able to do things, and in managing chronic diseases. And so next, what I'd like to do is hand it off to my co-presenter, Emily, to tell you more about that Zoom part of it, right?
Yes. Yeah, so like Dr. Hammel mentioned, we adapted Engage to be delivered remotely via Zoom. And when we started this process, we looked to the literature to for some guidance on adapting this in-person intervention to remote delivery. And we didn't find specific strategies. Instead, we learned that therapists are often more hesitant to remotely deliver interventions. They don't feel that they're well trained to deliver interventions remotely. And we learned that even though our clients were open to it, they also had some hesitations about the quality of services that they might receive when delivering or when receiving an intervention remotely. We also recognized that in this particular case, we had a pretty unique opportunity because the participants that had been recruited to these groups didn't sign up for the study because it was technology. They were recruited before COVID hit. They thought they were going to be in in-person groups. And then we come along and say, okay, so how about doing this on Zoom? And if you don't have a device or if you're not comfortable with it, we'll help you. And so we had this unique group that had a wide range of interests and comfort level and experience with technology. So we made several adaptations to the intervention delivery. And the ones that I want to highlight are on the slide here. We added a session 0 before that first intervention session. And the only goal of that session was that everybody would join the Zoom call, be able to unmute their mic and say hi. And that sounded very basic to, I think, many of us that were using Zoom regularly. And that session was really helpful to help participants get comfortable kind of with the screen, introducing themselves and navigating Zoom. And then the third bullet point here, we had a lot of technical support embedded throughout the duration of the intervention. So we had study staff behind the scene that were providing technical support as needed. We had multiple facilitators in each group, like Dr. Hammel talked about. And then we also provided a paper-based Zoom tutorial. Let's see. So after all of the intervention sessions were completed, we invited our stakeholders, including the group members, but also the group leaders and the study staff, to complete interviews to understand their experiences with what helped them to use Zoom. And among the 8 group members that participated in these interviews, 3 of them had loaned a device from the study. So we asked them to describe their experiences participating in the group sessions, what helped them to use Zoom, and what they might share with a new group member or facilitator who was going to join the groups. And we had 4 themes emerge. So our stakeholders identified advantages and disadvantages to the telerehab delivery model. Our group leaders and participants frequently commented on the ability to connect the specific group of people that were together who weren't necessarily from the same community or the same region of the city. It was also interesting to note that participating from the comfort of one's own home was viewed as an advantage by both participants and the facilitators. Stakeholders did acknowledge disadvantages that were largely related to social engagement over technology, which I think many of us can probably empathize with. They said that it was harder to break the ice at first. They maybe would have initiated more conversation before and after the meetings, and that it was also harder to get a read on the other people when they weren't actually in the same room as them. So learning to access the technology, so getting on the technology for the first time, and that included the Zoom software for some and the unfamiliar device for others, was an important part of our session 0. Throughout the interviews, we learned that factors that some stakeholders considered to be facilitators were considered barriers by others. And these factors included participants' interest in or their openness to learning the new technology, their past history using the technology, and then whether the amount of time that was spent training to the technology was adequate. Factors that impacted activity engagement, so actively engaging in the group sessions and in the group discussions and conversation during each of the remotely delivered sessions, emerged as a theme. And similar to the technology access theme, factors that some stakeholders considered to be facilitators were considered barriers by other people. These included the social experiences, such as the size and the personality of the group, navigation of tech-related disruptions that occurred during the group, and then the physical environment setup, including the availability of a hands-free device and the kind of power to manage the background noise in their environment, were considered both facilitators and barriers. And just as a quick example of how the group size was considered to be both a facilitator and a barrier, one of our facilitators commented about the size of the group, feeling that they had such a good discussion with all of their participants that they didn't want to break them up into separate breakout rooms. And yet a participant in the same group who was using an iPad to participate in the sessions found the group size to be challenging because they had to flick back and forth if someone on the other page talked. Since on an iPad, you can only see 4 people at a time on the screen. So we also wanted to hear from our stakeholders what would help future group members and future facilitators who were learning to use a new software or a new device to participate in the remotely delivered Engage sessions. Our stakeholders highlighted the importance of training to the Zoom software and then separately to the iPad or the computer as 2 entirely separate training processes. They also identified specific functions that would be important to talk about, including the mute button, the layout of the screen, and then what happens if somebody on the other end shares a screen, if they're still in the call or not. A couple more slides here. So stakeholders also talked about the vital role of social support from multiple sources, and that included the research staff, the group leaders or facilitators, and their family members. And one of our participants very directly told me, if my daughter had not been here to help, I probably still would not have had one good meeting on the Zoom. So although Zoom has become a relatively common software, especially over the last few years, our findings suggest that remotely delivered interventions require tailored training to the participants' needs. We also learned that training is more than a one-time event. And this was highlighted by an experience during one of the last group sessions where one of our participants, who typically relied on her daughter to mute and unmute her mic for her, managed to unmute herself when her daughter had stepped away from the group. She had no idea how she figured out how to do it. She just suddenly was talking. And so for some of the group members, gaining independence with the software in and of itself became a goal that enabled their social connectedness. Our group leaders or our group facilitators also talked about the support that they needed to modify their leadership style to help manage some of the social dynamics of Zoom and also to enable them to troubleshoot in the moment. I think it's easy to believe that they're tech savvy, they use this all the time, and some additional support was helpful for them. So overall, this study, the clinical side, and then also what we learned about delivering this remotely over Engage suggests that the feasibility of delivering group-based interventions such as Engage remotely and facilitating social connectedness using widely available video conferencing technologies such as Zoom may be enhanced by providing tailored training and ongoing support to both facilitators and group members throughout the process. So I think with that, I don't know if maybe time.
Emily. So at this point, we have time for a few questions. So I'm going to show the rest of our online attendees. Okay.
I have a microphone I would appreciate you to use. Thank you so much.
Good morning, and thank you so much for that presentation. I think this is so helpful and applicable to a lot of other chronic illnesses, and I've seen some examples of this in diabetes and other places. My question to you is, was there a motivation for waiting 4 to 5 years post-stroke? I feel like from a larger perspective, that's my experience in the hospital, we'd love to get people signed up for this kind of thing earlier.
Yeah. Yeah, and let me tell you that we are now testing it cross disability and cross aging, and right, because it's all applicable at the same kinds of levels. We happened to get a group that was 4.5 years when we recruited, but that ranged anywhere from 3 months on up to 20 years post. And the average was 4.5, which tells you something, right? We only required that they be out of the hospital for 3 months. So we just said, since your stroke 3 months, right? And that you had finished rehab, because we didn't want to interfere with that, right? Kind of, even though I think this could be in rehab, but we wanted it to be a community-based intervention. So that was our only criteria on that front going in. And this is who came in. So it's showing you, again, we had some younger folks that, you know, were new to stroke, right? And then we had other folks so that were up to 20 years post and still like incredible social isolation, depression, you know, not participating. And it was so interesting to see the two go together, because they influence the people younger to stroke big time, to say, don't sit and wait on this, like just get involved, right? You know, kind of thing, and worked on goals together. So that was, I think, the advantage of the social learning part of it. The guided discovery helped you do it yourself, right? Like to strategize on your own how to do this, right? But the social learning had an incredible impact. Mm-hmm.
Other questions?
I have one. So I have a question for Ms. Campbell. And this is with the transportation, related to the transportation. You mentioned the survey for individuals with mobility issues. I am wondering whether or not if you've thought about doing a survey for individuals that are deaf blind.
Thank you. I think I heard you. Can you hear me? Can you hear me? Yes. That survey that I referred to was conducted by a consortium of federal agencies under one of the centers funded by this National Center on Mobility Management. And again, this was all looked at from the federal perspective. So from the federal perspective, they were interested in what do state and local agency representatives and service providers see as the barriers to transportation coordination. So it wasn't specific to disability type or diagnosis. It was just in general, here's this money available through these formula grants and these competitive grants. What are the barriers you're experiencing in utilizing these resources to try to deliver transportation services to older adults and people with disabilities? So it wasn't targeted in the way you're suggesting. But what I think your question, if I can use your question as an opportunity to make the observation, which I think this panel really illustrates, is on either end of my presentation, we have these very innovative programs, exciting, innovative intervention programs that really are promising. What we lack is how do we get them to scale? We lack a pathway. And that's what I was trying to illustrate with all the fragmentation in the FAST Act, for example, is you've got all these different pockets of funding, but they're little pockets and they require grants, and there's not really a pathway for taking some of these innovative intervention programs, the results, and taking them into actually larger scale demonstration programs, and then which can become line item budgets. So that's where the federal government could play a really important role. And it would require, you know, very, very coordinated research programs and demonstration programs. But I think that's where we see this huge gap. And it means that people who aren't involved in these innovative research programs aren't benefiting. And particularly this involves lower income people in rural areas. We could point to that specifically. But I think that's what this panel really dramatizes, is how do we go from these really programmatic programs that produce mobility for all at a wider scale level. Thank you for your question.
Thank you, Margaret.
Is it okay to jump in on that one just really quickly,
Sure.
just to say that on another NIDILRR project that we're involved with called ADA Park, which is the Americans with Disabilities Act Participation Action Research Consortium, we actually did do a survey of over 2,000 people with disabilities. And this was consumer directed. They chose the questions and it went out via many disability communities, including the deaf community and people who identified as hard of hearing. And so we were able to look at barriers and supports, and as well as the impact on participation for diverse disability groups. And I'm happy to share that with you. And there's lots of data there that if you'd like to do a sub-analysis just on deaf and hard of hearing, we have we had a good response rate, from that community.
Thank you, Joy. One thing I will say about that as well is the data Margaret presented from the Access study. That was a TechSAge project that included 3 groups of older adults with long-term disabilities: long-term vision, hearing, and mobility disabilities. And we have data from 60 older adults who are deaf and use American Sign Language. That data has yet to be analyzed. So we have lots and lots of data to look at those specific challenges for the deaf community. I do not believe we had any deaf-blind participants in that sample. John.
It seems to me that one of the problems with the federal innovative policies and innovative programs is that they're innovative in their programs and their approaches using traditional transportation methods and transportation options. So for example, in Katie's presentation, she talked about street bikes, right? Which is a transportation option that is being run by private industry and not by traditional transportation approaches. Now, there are problems with it, and one of the biggest problems is the bicycles and the scooters, which solve last mile transportation issues, aren't accessible. So what if we had accessible scooters? What if we had accessible modes that people could get from the train stations or to their CDSs or their local pharmacies, and they could go shopping and they could carry their bags back with them if they go shopping, but they don't need to use an Uber because it's too close, and using other traditional sort of transportation options that are accessible are unsustainable because you can't do door-to-door service forever for everybody that needs it. So what are the thoughts about trying to goose the system with some other technology that may be more accessible and more useful for people with disabilities and older adults within the greater scheme of things? Thomas.
John, may I respond to that observation and that comment?
Yes.
Do we?
Oh yeah, go ahead. You don't have to ask me.
I don't want to violate our time parameters here. Well, actually, I mean, within the provisions of the FAST Act, just take that as an example. There definitely was allowance for what you're talking about. It was definitely allowed. Problem is, when you take the funding levels, roughly 250, 280 million per year across all the states. Remember, these are formula grants across all the states. It's a trickle. It's a trickle. So it doesn't generate what you're talking about at a sufficient scale. If you look under, there are 180 different programs that were implementation programs, for example, that were under CAM. That's the Council and Coordinating Council. But they're, again, minuscule, and there's no mechanism for harvesting what are the promising results from these and trying to scale them up. So there's lots of experimentation. And they funded technology centers. I mean, again, under the FAST Act, they're not technology centers, but technology and statistical programs. But again, it was such a trickle. It was, when you look at the funding levels across the entire nation, these are formula grants. So what did states get? They got, maybe 10, somewhere between, and it's tribal organizations too. So somewhere between $5 and $10 million to fund these both traditional investments in the capital improvements, which included mobility management systems, et cetera, as well as the non-traditional investments. So the funding levels are so low. What we're investing in this is just, I think it's very, very difficult to get to scale. And, you know, what I would foresee if I could manage this would be, we really have a mechanism for harvesting these promising results from studies like Joy's and Katie's, et cetera, and using them to design social experiments, demonstration studies, demonstration programs that are social experiments that really can have the capability of going to scale.
Thanks, Margaret. This is Wendy. I just want to follow up on that with a question for Katie. Given your role in implementing these things and given our goal of trying to think about top priorities, what's maybe your top 3 wish list of, especially with respect to the technology side, where would you encourage us to be investing our time and energy in research and development? Here's your chance to guide us. Not to put you on the spot or anything.
Yeah, I mean, that's kind of hard for me because I'm trying to put like my science research hat on. I mean, I think can you hear it? Okay. My top 3 priorities for research for you all.
Research and development.
Training,
anything technology related. What do you want us to do?
Yeah, I mean, part of it, 3, okay. Well, I think part of it, I think I go back a lot of times to that, how do we think about the universal design, universal accessibility, and even kind of what John's question was bringing up. Okay, yeah, we have these scooters and e-bikes for last mile connectivity and they're not accessible to all. I think that's because certain things are being driven by how we've always thought from that kind of ableist perspective. So kind of a dream would be, and this is even, so kind of the dream from, as people are thinking about how do we do a complete trip. I don't know how to phrase this very well, but if we're doing a complete trip, how are we coming at it from the other perspective? And so from both, when you're talking then in the aging side too, as well, it comes up a lot of, you know, we're a very ageist society, we're ableist, we're ageist. So how can we think about, you know, what works for the person who's the most vulnerable is gonna work for everyone. So yeah, when you're researching, which this group already is doing that, right? Because that's what your focus is people aging with disability. I think also the scalability is a good point. I mean, we kind of talked yesterday about some of these cool technologies are being developed, great, but how are you going to be able to get that out more people, and how is that going to be able to not just help the one person who can afford it and has this specific need. And a third thing, I'm answering your question very generally and I apologize, but, and I think another huge focus, which kind of relates to the other 2 is the scalability, but also, well, it maybe is too redundant. I was gonna say kind of how is it equitable across all of our systems. I think we have it. It relates to the scalability, but I think it's just a little bit different perspective of a lot of times we're focused on, we're just not talking to the right people and we're not thinking through it. It's probably redundant, the scalability, but the access to the low income people in particular, we don't experience as much in Metro Atlanta, but the rural aspect is a huge aspect. But yeah, thinking about how are we, again, getting at those most vulnerable populations and getting, embedding equity into our decisions as we're making them. Does that answer?
I like that. That's awesome.
Okay.
I think I'm not good at spot.
This is Amy. So what I just wanted to add as you're thinking about that, so oftentimes for state policymakers and people that are helping, we want to hear about these projects, and I hope I can talk with Joy and Emily, because I think it would be great if we include some of this in our device distribution. But I think that for like states and the federal government, when we're thinking about these different research projects or development or technology, we have to think like insurance companies, for better or for worse. What they will approve, what they will fund, et cetera. So it's really great that we're able to, I don't have to tell you all about data and outcomes because you're producing that and that's what people want to see. But we also need to look at the sustainability from a financial perspective. And I know that isn't always maybe the first and foremost, maybe that's like for me and others to think about, but that's probably going to be the first, whenever somebody brings kind of a demonstration or a pilot to us in state government or a technology or whatever, that's kind of like the first question we ask. So.
I would say from pretty much every policy advocacy if we're talking to elected officials at the federal level, appropriations, all of our requests, we always try to frame it in terms of we need to get to the healthcare to the actual insurers, but we always are trying to point out the now blanking every year they look at the costs of different care. Not return on investment from them, but from the how much it costs to provide different types of care based on your state and where you live. There's a database, I'll look it up. But if you look at that, the cost of not making it possible for people to live in their community is so much more dramatic. And our systems are set up to, someone can't live in their community. And so they're ending up in a nursing home and qualifying for Medicaid and losing all of their other financial and then just the ripple effect. So if you start framing some of your research and why it's important to do this and be able to scale this in terms of the way the cost savings, I'm saving you $70,000 per year on that individual. It might cost $10,000 to deliver the service, but hey, it's gonna be $80,000 to do this. I think that helps a lot too in trying to make a case for why but it doesn't quite get at what Margaret, the way they're already set up, but if we can just kind of be having those conversations when we're having those conversations at the federal level and the state level, how you're thinking about funding, we try to bring that up all the time.
Thank you very much. So we have overshared our time for discussion, but that's okay. It's time for a break. So I invite our in-person attendees. We're going to take a 15-minute break. We do have some snacks from yesterday. Please help us not to waste food. And lunch will be served at 1 p.m. Central.